Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 339 of our pharmacotherapy series, which majors in drug interaction. The first question reads, JAP is a 69-year-old previously healthy male who was admitted to the medical intensive care unit with lower left lobe pneumonia, and he has developed septic shock. His hospital course for the first 18 days of admission consisted of a worsening bilateral pneumonia characterized by profound hypoxia and acute respiratory distress syndrome, abbreviated as ARDS. JAP is currently deeply sedated and receiving neuromuscular blockade to manage his ARDS, high peak inspiratory pressures, abbreviated as PEEPs, and low oxygen saturation, abbreviated as SaO2. His medications are as listed below: propofol IV infusion and fentanyl IV infusion for sedation and analgesia. Cisatracurium IV infusion for neuromuscular blockade. The goal is to improve oxygenation, PaO2 to FiO2 ratio. Pantoprazole IV for stress ulcer prophylaxis. Heparin subcutaneously and pneumatic compression boots for deep venous thrombosis prophylaxis. Hydrocortisone IV for corticosteroid insufficiency in critical illness. Amikacin IV and imipenem C-Listatin IV for DA5 treatment of a multi-drug resistant organism. Norepinephrine and vasopressin IV infusions for septic shock secondary to pneumonia. Ophthalmic ointment to lubricate eye while on prolonged neuromuscular blockade. Lactated ringers IV infusion for hypotension secondary to septic shock. His vitals are as follows: a body temperature of 101 degrees Fahrenheit, a heart rate of 105 beats per minute, a respiratory rate of 20 breaths per minute, a blood pressure of 95 systolic 60 diastolic. His laboratory values are as follows: his ABG is as follows: pH 7.30, PCO2 of 42, PO2 of 80, a bicarbonate of 19, an SaO2 of 90% on mechanical ventilation. Assist control RR20. His tidal volume is 400 milliliters. PEEP 10 FiO2 50%. Pause the video and carefully scrutinize the table illustrating his labs before advancing to the next slide. Patient JAP's train of 4, abbreviated as TOF, is 0/4. A peripheral nerve stimulator, the train of 4, is a clinical tool used to monitor neuromuscular blockade. The train of 4 scale includes the following. 0/4 indicates that no twitch elicited. Neuromuscular blocker agent occupies 100% of postsynaptic nicotinic receptors, and a 100% blockade, whereas 4/4 indicates that less than 75% of the postsynaptic nicotinic receptors are blocked. The goal of neuromuscular therapy is to achieve an adequate neuromuscular blockade. A train of 4 of 1/4 or 2/4 correspond to 80% to 90% of receptors blocked, or the desired clinical effect, e.g., accepting ventilation and not over-breathing the ventilator, with the lowest dose of neuromuscular agent necessary. Describe JAP's risk factors for drug interactions. There are several risk factors for drug interactions in critically ill patients. Critically ill patients are susceptible to drug interactions as a result of a debilitated condition and/or disease state, e.g., changes in physiologic pH and body temperature, electrolyte imbalances, organ failure, etc., as well as the multitude of medications prescribed as treatment. ICU patients also have altered pharmacokinetics, placing them at an increased risk for an interaction. These changes include the following: decreased gastrointestinal absorption of enterally administered medications due to the following: hypoperfusion from shock, increased stomach pH from PPI and histamine blocker therapy, decreased gastrointestinal motility, drug effect on carrier proteins, for example, PGP, decreased subcutaneous absorption due to the following: edema, vasopressor therapy, and disease-induced peripheral vasoconstriction, increased volume of distribution for hydrophilic medications due to increased total body water from fluid resuscitation and third spacing, altered free drug fraction due to increased alpha-acid glycoprotein from systemic inflammation and decreased albumin plasma concentrations, and half-life and clearance may be affected from decreased hepatic blood flow, renal or hepatic insufficiency, and induction or inhibition of hepatic enzymes by drugs. Patients without renal insufficiency may exhibit augmented clearance. The mode of mechanical ventilation that is used most commonly today is positive pressure ventilation, whereby air is forced into the lungs to improve gas exchange. The use of mechanical ventilation may also affect drug pharmacokinetics by decreasing cardiac output secondary to reduced preload, which in turn may compromise perfusion to the liver and kidneys as well as GFR and urine output. This effect is most pronounced in patients who are hypovolemic. These hemodynamic changes can result in a decrease of the clearance of several drugs. JAP has several risk factors for drug interactions. Many of his risk factors are patient-specific, including JAP's age, organ dysfunction, and acute medical conditions. Additional risk factors are the extended hospital stay in the ICU and multiple medications. JAP's specific risk factors are outlined below. The patient risk factors are as follows. 1. Age. He is 69 years old and may have altered pharmacokinetic and pharmacodynamics. 2. Renal dysfunction. His baseline serum creatinine was 1.0 mg per deciliter and the current serum creatinine is 1.8 mg per deciliter, pointing to decreased renal clearance. 3. Mild hepatic dysfunction. AST 105 units per milliliter and ALT 85 units per milliliter, signifying a decreased metabolism. 4. Pneumonia. His body temperature is 101 degrees Fahrenheit, WBC 14.6 times 10 power 3 per microliter, polys 80%, bands 12%, which signifies an increased catabolism. 5. Hypotension, result of shock. Blood pressure of 95 systolic 60 diastolic on norepinephrine, vasopressin, and lactated Ringer's solution due to a decreased clearance. 6. Hypothermia. This is shown by a body temperature of 101 degrees Fahrenheit pointing to an increased clearance. 7. Hypophosphatemia. Phosphate of 0.9 mg per deciliter, pointing to an increased neuromuscular blockade. 8. Norepinephrine and vasopressin infusions. Potential for decreased blood delivery to liver and kidneys. 9. Mechanical ventilation. It may lead to a decreased cardiac output. Other risk factors are as follows. 1. Polypharmacy. There is a risk of adverse drug interaction increases with multiple medications. 2. Duration of hospital stay. 18 days makes him susceptible to hospital-acquired conditions and subsequent drug therapy. The medical team is concerned that JAP's condition may have worsened. He may have had a neurologic event, e.g., stroke, in the night. JAP is clinically unstable to bring to computed tomography. The team needs JAP to be alert for purposes of conducting a neurologic examination. To undergo the examination, JAP must have his neuromuscular blockade discontinued and sedation lightened. 1.5 hours after discontinuation of cisatracurium, JAP is still not moving, as shown by a TOF 0/4. The medical team feels JAP's cisatracurium's paralytic effect should have worn off by now and is concerned about his prognosis. The medical team ask the clinical pharmacist to review JAP's case and affirm that the neuromuscular blockade has worn off. What outcome do you expect? After reviewing the case, the clinician identifies potential drug condition or disease and drug-drug pharmacodynamic interactions that may contribute to the prolonged neuromuscular blockade. These interactions are discussed below. Background. The incidence of ICU-acquired weakness, polyneuropathy and myopathy in ARDS patients is 34% to 60%. This condition can last for months to years and can severely affect a patient's quality of life. There are several risk factors for ICU-acquired weakness that includes prolonged mechanical ventilation, number of days with dysfunction in 2 or more organs before awakening, corticosteroids, female sex, toxins, e.g., botulism, neuromuscular disease states, e.g., Guillain-Barré syndrome, severe electrolyte imbalances, prolonged recovery from neuromuscular blockers, deconditioning, length of vasopressor support, and hyperglycemia, just to name a few. Neuromuscular blockade alone has been associated with ICU-acquired weakness. However, in a multi-center, double-blind trial, investigators found no statistical difference in ICU-acquired paresis between cisatracurium and placebo groups at day 28 or ICU discharge. Prolonged recovery from neuromuscular blockade may occur in patients with organ failure and/or conditions that affect the overall clearance of the neuromuscular blocking agent, e.g., decreased metabolism of a parent drug, decreased elimination of the parent drug, and/or the active metabolite. In addition to that, certain disease states, conditions, or drugs that may potentiate a blockade may also lead to an increased recovery time. Next we will look at drug condition and disease interactions. Let's begin with pharmacokinetics, emphasizing drug metabolism or elimination. The non-depolarizing agent, cisatracurium, is a benzylisoquinolinium compound. It is one of the 10 isomers of the intermediate-acting neuromuscular blocker, atracurium. It is primarily eliminated by Hofmann degradation. Optimal breakdown occurs at physiologic temperature, 37 degrees Celsius or 98.6 degrees Fahrenheit, and pH of 7.40. This process results in therapeutically inactive metabolites, monoquaternary alcohol, monoquaternary acrylate, and laudanazine. Cisatracurium's organ-independent elimination is a benefit for JAP, because he has renal and hepatic insufficiency. However, because cisatracurium is degraded by the Hoffmann process, alterations in pH and temperature will affect the elimination of the drug. For example, the neuromuscular blockade effect is prolonged with acidosis while elimination is enhanced with an increase in pH. Additionally, hypothermia decreases the elimination of cisatracurium whereas hypothermia accelerates it. In ICU patients, the recovery rate from neuromuscular blockade is reported to range from 45 to 75 minutes after discontinuation of a prolonged cisatracurium infusion. Because JAP has both a fever, 101 degrees Fahrenheit, and metabolic acidosis, pH 7.30 and bicarbonate of 19, it is difficult to predict the clearance of the neuromuscular blocker. And now we will look at pharmacodynamic interaction. A second condition that may add to JAP's prolonged blockade is his low phosphate 0.9 mg per deciliter. Phosphate is a building block of adenosine triphosphate. ATP produces energy via an enzymatic reaction by releasing a phosphate group. This reaction is necessary for physiologic and metabolic functions including muscle contraction. Therefore, a patient with hypophosphatemia is at risk for a myopathy. Let's discuss drug-drug interaction. Beginning with pharmacodynamic type, i.e. additive effects of medications. JAP's medications may also have additive effects with cisatracurium. A rare adverse effect of amikacin is neuromuscular blockade. The mechanism of blockade involves inhibiting acetylcholine release by competing with calcium at the preganglionic nerve terminal and to a smaller degree non-competitive blocking of the receptor. Corticosteroids, e.g., hydrocortisone, may also enhance blockade and increase recovery time. Proposed mechanisms for steroidal ICU-acquired weakness include increased muscle sensitivity to corticosteroids because of lack of movement and skeletal muscle atrophy from the steroids' catabolic actions. Additionally, corticosteroids may cause myopathy by denervation. Corticosteroids have been shown to inhibit the nicotinic receptor. When combined with the neuromuscular blocking agent, vecuronium, this inhibition is potentiated. It is thought that this interaction is more likely to occur with neuromuscular blockers that have a steroid structural ring, such as the aminosteroid, e.g., pancuronium, pipcuronium, vecuronium, and rocuronium. However, there have been case reports of prolonged paralysis with the benzylisoquinoliniums, e.g., atracurium, cisatracurium, doxacurium, mivacurium, and D-tubocurarine. JAP may need a longer period than an hour and one-half to recover from his paralysis because of the following factors: decreased elimination of cisatracurium as a result of acidosis, hypophosphatemia, and medications, i.e. amikacin and hydrocortisone. JAP should also have his phosphate slowly repleted. The next question reads, the medical team asks you to explain the drug interactions affecting the antibiotic efficacy of JAP's regimen. After reviewing the case, the clinician identifies potential drug-drug physiochemical interaction, as well as drug condition and drug-drug pharmacodynamic interactions. The mechanism of action of these interactions is discussed below. We will now look at drug-drug interaction, with an emphasis on physiochemical inactivation. It has been well documented that the co-administration of beta-lactam antibiotics with aminoglycoside antibiotics can lead to inactivation of the aminoglycoside. The mechanism involves the amino group of the aminoglycoside antibiotic forming an inactive amide with the beta-lactam ring of penicillin antibiotics. Because penicillins have wide therapeutic index, this interaction primarily affects the efficacy of the aminoglycoside antibiotic. This interaction has been shown to occur with the extended-spectrum penicillins, e.g., aslacillin, carbenicillin, meslacillin, ticarcillin, and piperacillin. JAP is currently on amikacin and imipenem C. Statin antibiotics for treatment of a multiresistant organism. According to the literature, amikacin is the aminoglycoside that is least susceptible to this interaction. Additionally, no inactivation of amikacin was observed when incubated in C-Statin 120 micrograms per milliliter human serum for 48H at 37 degrees Celsius. This inactivation increases with contact time and is directly proportional to the concentration of penicillin. The rate of elimination of aminoglycoside and imipenem C. Statin may be increased because of JAP's renal dysfunction. This would increase the contact time of the medications. Recommendations for JAP's antibiotic therapy include administration of medications separately. Serum concentrations of aminoglycosides should be assayed immediately after drawn, or if analysis is delayed, freeze at -70 degrees Celsius. And because of his renal dysfunction, close monitoring of aminoglycoside serum concentrations is indicated. And now we will look at drug condition or disease interaction with an emphasis on pharmacodynamic interaction. The pharmacodynamic actions of amikacin may be decreased because JAP is acidotic. Amikacin enters the bacterial cell and reaches its site of action in 3 stages: ionic binding, energy-dependent phase 1, EDP1, and energy-dependent phase 2, abbreviated as EDP2, transport or uptake. Ionic binding to the outer membrane, at physiologic pH, amikacin, pK, A8.1, is a highly ionized basic cation. It binds to anionic lipopolysaccharides, abbreviated as LPSs, polar heads of phospholipids, and proteins on the outer cell membrane of gram-negative bacteria and phospholipids and teichoic acids of gram-positive bacteria. This leads to displacement of cell wall magnesium and calcium bridges that link lipopolysaccharide, and the result is the formation of pores in the cell wall where amikacin can enter into the periplasmic space. EDP1. Amikacin is transported across the cytoplasmic membrane. EDP1 is dependent on pH and oxygen. Amikacin activity will decline in low pH and anaerobic conditions, e.g., abscesses. EDP2. Amikacin is transported to the site of action, binding to the ribosomes. And finally, we will discuss drug-drug interaction, with an emphasis on pharmacodynamic interactions that are additive or synergistic effect of medications. Penicillins form a covalent bond with the enzymes, the penicillin binding proteins, abbreviated as PBPs, specifically transpeptidase, endopeptidase, carboxypeptidase, inhibiting their action. These enzymes are needed for the final step of bacterial cell wall synthesis, the cross-linking between peptide side chains on the polysaccharide backbones of the peptidoglycan. Cell wall inhibitors such as penicillins and vancomycin may expedite aminoglycoside entry into the bacterial cell, resulting in synergistic effects when treating some organisms. JAP is critically ill with renal failure, ARDS, pneumonia caused by a multiresistant organism, septic shock, and a metabolic acidosis. It is important to closely monitor his aminoglycoside therapy for efficacy, that is peaks, and toxicity, that is troughs. This case illustrates the difficulties surrounding drug interaction identification, assessment, and follow-up intervention. Clinicians must recognize that literature to support the presence of a drug interaction is often scant and not always definitive, and the optimal intervention may rely on clinical judgment. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 340.